Hi, everyone. Good evening, good morning, good afternoon, and welcome to our SIOP CEDAR webinar tonight. My name is Trisha Susay-Raj, one of your co-moderators today. I'm a pediatric oncologist at the Queensland Children's Hospital based in Brisbane, Australia. I'm also an active member of the SIOP Education and Training Committee and the SIOP CEDAR project. So along with the International Society of Pediatric Oncology, or SIOP, we have the CEDAR project, which is the Childhood Cancer Early Diagnosis and Appropriate Referral. This is with a strong collaboration with IPA, the International Pediatric Association. I'm joined today by my co-moderators, Dr. Daniel Moreira, who is a pediatric neuro-oncologist at St. Jude Research Hospital in Memphis, and also an active member of the SIOP Education and Training Committee and the St. Jude Global Alliance, as well as Dr. Michelle Farmer, a pediatrician from USA, who is co-chair of IPA's Strategic Alliance Group on Non-Communicable Diseases, and has been a great support in the SIOP IPA collaboration for this CEDAR project. So, as I mentioned, this project is collaboration with IPA with the aim to improve the knowledge and understanding of general healthcare providers about the initial care of pediatric patients suspected of having cancer. Today, we're very fortunate to hear practical advice from oncology experts from around the world about how to identify children with the suspicion of brain tumours. Our speakers today will be Dr. Farah Bashir from Pakistan with a case scenario, followed by Dr. Eric Bouffet from Canada on when to suspect brain tumours, and then Dr. Naureen Mushtaq from Pakistan for approach for diagnosis, initial management, and referral of brain tumours. We will be accompanied today by a panelist, Dr. Anthony Figaji from South Africa, Dr. Shaarna Devel from the United Kingdom, and Dr. Hikari from Indonesia. Some housekeeping instructions today. There will be simultaneous Spanish translation. So please, if you wish to join the Spanish stream of this webinar, please click on the world globe icon with interpretation on it, which will take you to the Spanish stream, and there will be an English and a Spanish stream concurrently. If you have any questions, please click on question at any point. There is no voice option for the audience, but please type your questions. We will aim to answer any relevant questions that we can live, and otherwise the text answers will come from the experts where possible. There will be a dedicated question and answer time after the panel discussion right at the end, and there is CME, continuing medical education credit available as well. So I will now introduce our first speaker, who's Dr. Farah Bashir, who will be presenting a case scenario. Dr. Bashir did a fellowship in pediatric hematology and oncology from the Combined Military Hospital in Rawalpindi. Currently, she is doing a fellowship in pediatric neuro-oncology at Aga Khan University Hospital in Karachi under the mentorship of Dr. Naureen Mushtaq. And there will be, she'll present her case scenario now.
Good afternoon, everyone. I am Dr. Farah Bashir. I am a fellow in pediatric neuro-oncology at Aga Khan University Hospital, Karachi, Pakistan. I'll be sharing a case of pediatric brain tumor who was diagnosed late. He was a 15-year-old boy who has history of vomiting for last 3 months. For these complaints, he went to general practitioners and general pediatricians, but he was not diagnosed in those 3 months. Even his endoscopy was done, which was normal. Patient was started on antidepressants, considering that his vomiting was related to his stress regarding his studies. However, he came to emergency department of our hospital with history of right-sided weakness and slurred speech for 2 hours. Upon detailed history taking, it was observed that he had history of headache along with vomiting for past 3 to 4 months. His MRI brain was done that showed multifocal heterogeneous enhancing lesions in the fourth ventricle, pineal gland, suprasellar cistern. Unfortunately, his disease has metastasized to the spine as well. His surgical resection was done, BP shunt was placed, and histopathology was consistent with medulloblastoma, CNS, WHO grade 4 classic histology. The MRI brain that was done 72 hours postoperatively showed surgical changes along with suspicion of residual disease. His chemotherapy, concurrent chemotherapy, and radiotherapy was started 6 weeks after surgery. His chemotherapy consisted of weekly vincristine and daily carboplatin, and radiotherapy was given a total dose of 55.8 gray. Patient MRI was done after completion of radiation therapy, and it showed no evidence of disease. His maintenance chemotherapy started with vincristine, cyclophosphamide, cisplatin, 6 cycles at 6 weeks interval. Patient was well compliant, and they remained on regular surveillance, and he was followed up after every 3 months. Unfortunately, after 1.5 years of completion of treatment, his disease recurred, and he died at 2 years post-diagnosis of recurrent disease. If the symptoms of vomiting and headache has been picked up early, or if the patient CT brain or MRI brain has been done early, the outcome would have been different, and the disease may not have metastasized to the spine. I thank you all for patient listening.
Wonderful. Thank you, Dr. Farah. We're going to pass on to the next speaker. As Dr. Trisha mentioned, if there's any questions, use the Q&A function as the microphone is enabled. So now it's my distinct pleasure to introduce Dr. Eric Bouffet. He's a world-renowned pediatric neuro-oncologist based at Sick Kids in Canada, and more recently, the St. Jude Global Neuro-Oncology Program. He has a wealth of experience in terms of the clinical aspect, but also building capacity for brain tumors, and former president of SIOP. Eric, go ahead.
So it's really a pleasure and a privilege to be here, and I can see it's an impressive meeting with over 200 participants. I'm really glad to be with you, going to talk on a very, very complex and difficult topic. And in fact, going back to the beginning, there was a fantastic paper with a seminal work by Scott Howard and the team, looking at the reason for treatment failure. And one of the first reasons for treatment failure is a lack of diagnosis. And this is published in this paper, which is on the bottom of the slide. I'm happy to share any slide with you and all the content of my presentation. So looking more specifically at some data, I wanted to share with you, this was a poster that was presented at the SIOP meeting, South Africa meeting a few years ago, showing that in Mauritania, they didn't see barely any patient with brain tumor compared to other diagnoses. The same in Ghana, you can see that's 1% of all tumors seen at their pediatric oncology. And when we look at the data, we say, so there are 2 questions here. One is, where are the patients, and why do we miss the brain tumor? Where are the patients is a big question that relates essentially to low and middle income countries, where it seems that a number of kids are not registered, or they are not even diagnosed because they don't make it to the hospital. Why are they missed? There have been a number of papers. And I think one paper I really enjoy, I love, I read it again and again. It's from 1996 from a team in London, and they provide very interesting data. One of the information that you see here is very important, that when you look at the patients who have been diagnosed with brain tumor and the time to diagnosis, it's very intriguing that the children who had the longest time to the diagnosis were alive. When the time was shorter, they were not alive. And that's an important consideration. I go back to what Farah said. She said that if the diagnosis had been done earlier, this patient would have survived. And it's not clear, in fact, in the pediatric neuro-oncology literature that this is true, at least in a high-income country. I will go back to this in a few minutes. So the second issue here is, what are the symptoms? And you can see that the symptoms are very general: vomiting, headaches, change of personality. When you are a teenager, you always change in personality. And there are more specific symptoms. And in general, when the symptoms are more specific, they may lead to a faster diagnosis. So, and when you look at these non-specific symptoms, they are often associated with a longer time to diagnosis because they are in fact non-specific. And when they describe the symptoms, you can see the presenting symptoms were described here. And they were also described according to the age of the child and showing that the symptoms are different according to whether you are a toddler with sleepiness, irritability, which are the most common symptoms, and older patients with different symptoms, and the teenager or older children and teenager with also some different symptoms. And I really love what was said in this paper, that you have to be really careful and you should consider patient or parents' concern about symptoms. That's the second paragraph. But also that a number of parents, they come to you, and we are in easy situation, we oncologists, because we often see the child when the diagnosis is done. So the main issue is in the community, the people who are in contact with the kids before they are diagnosed. And as I say, one of the questions is, will earlier diagnosis save lives? And there are many examples that suggest that this is not the case in a high-income country. There was a fantastic work done by Dr. Halperin at Duke University showing that the shorter the symptoms in medulloblastoma, the higher risk was the medulloblastoma. This has also been seen or shown in DIPG and brainstem tumor, in ependymoma by Jan Polak, in spinal cord ependymoma, astrocytoma. This is a work that we did in France when I was in France 30 years ago. But this may be true in low and middle income countries when patients die before diagnosis or where they are diagnosed in extremis with advanced disease. So we have some data from low and middle income countries. That's a work that was done by Laila Essisen and Dr. Kadoumi at St. Jude, looking at the Moroccan data and showing that, for example, in high risk disease or in malignant disease, medulloblastoma, and in low-grade glioma, we could see that there was certainly a delay in the diagnosis with a number of patients seen after several months of history, and showing that there was not really a major difference between malignant tumor and low-grade glioma, because I know that low-grade glioma is one of the focus of this topic. They looked at also the type of symptoms that were presented at the consultation by the different patients. 27 patients, 76 consultations. You can see that on average, patients were seeing the doctor 2 or 3 times. And with the main concern were essentially headaches and vomiting here, which are very, very general signs and symptoms. And looking at the patients who had longer than 4 months, you can see that there are various symptoms: headache, precocious puberty, signs of increased cranial pressure for most of them, and some had visual symptoms considered by the doctor as a squint without any other concern. I also had the opportunity and the privilege to go to Ethiopia, and really they did a fantastic work that has not been published yet, but showing in a population of over 80 patients that the median time to diagnosis was in the majority of the patients, you can see, more than 6 months. Ethiopia is a very large country with essentially one larger center that is doing neuro-oncology. So you can see that in low-income country, this is a major issue here. And they try to dissect the reason for the delay. And there was, one of the reasons was delay before seeking medical advice, between medical advice and referral, and between referral to intervention. And you can see in every case, there are significant delay here. 1 month between the diagnosis and the surgery is a delay which is really, in my eye, unacceptable. And they looked at the reason. There were financial reasons, religious reasons, traditional medicine, things that we may not really often see in high-income countries, but are much more common and challenging in countries where there are beliefs that we should first look at or see the healer. And this is an example of a patient who traveled for 6 months before reaching Addis with this major change in his face and due to the tumor here. And as a result, at least in Addis, a number of patients did not undergo surgery for different reasons. They fell by surgeon because they had no material, or because they were not keen to do surgery, or by parents, or they died before the intervention. So one of the issues is the brain tumor have no specific symptoms in many cases. And it's certainly much easier when you present with neurological symptoms such as neurological deficit or things that can guide you towards something in your brain. But I want to show you a few examples of low-grade glioma where the symptoms can be very delayed. That's the case of a tactile brain tumor where patients have no other symptoms than headaches, and sometimes they have some school problem, but the diagnosis of tactile brain glioma can take sometimes several years. There were a number of papers. This paper is a great paper by Dr. Giorgialo on spinal cord tumor, showing that also the delay can be very long with essentially back pain, but also scoliosis, which can be considered as idiopathic scoliosis, and in fact is in a number of cases related to the presence of a spinal cord tumor. With, in fact, in the low-grade glioma, the evidence that you often have also a widening of the spinal cord canal that can tell you that this has been here for a very, very long time. Again, another cause is epilepsy, and sometimes the CT scan cannot pick the brain tumor. Look at this lesion here, which is very subtle on the MRI scan and certainly would not be seen on a CT scan or barely be seen on a CT scan. And this is an issue in countries where you have only the CT scan as a screening tool. And there are other reasons. So that's a recent paper from Dr. Kadumi and his team looking at psychiatric symptoms and showing that psychiatric symptoms can be very misleading with a number of symptoms that are associated with the onset of low-grade glioma and craniopharyngioma. So in that context, what is important? Is part of your training. Please spend a few days with your ophthalmologist, because you will see this as a normal fundoscopy, this has a papilloedema, and this has an optic atrophy, and share the finding and share the knowledge with other people. And a dream is that every single medical student has this opportunity to go and to see this, because this is an exam, a test that can save lives. I will not expand too much here because I know that Dr. Mushtaq is going to talk about, but there have been initiatives to try to reduce the time between diagnosis, initial symptoms and diagnosis. One of the most famous examples is a work by Dr. David Walker, who was linking a national database and for hospital healthcare and the National Cancer Registry, looking at the interval between the first consultation to the GP to the final diagnosis. Just to say that the same type of work has been done and completed in Jordan by Dr. Amayari with different tools, because there was no national database. And she did this during the COVID, which was also a major setback and a major obstacle. But she did a great work, and it should be taken as an example, translating the document of Dr. Walker into Arabic and teaching in different hospitals, but also different schools and different cities, and trying to approach as many people as possible to share the knowledge and to disseminate the information about brain tumor. And this can also be done by app, and this is an example of an app that was being developed on Coped by Dr. Liliana Vasquez from Peru, that could certainly be translated into different languages. To finish, I want to say there is also another way to try to achieve an earlier diagnosis is by identifying patients and family at risk. That's a work that was done by Dr. David Walkin and Dr. Anita Villani in Toronto in families with P53 mutation, deforming, showing that if you implement a screening in these families and trying to detect tumor at an early stage, you can see that you can save lives. So that's the survival curve of patients who were part of a screening program and survival curve of patients who are not part of the screening program. And this has also been done in the context of mismatch repair deficiency. That's a work by Carl Duno and Ace Ekran, and with the team in Toronto, and showing that you can detect, particularly in the context of brain tumor and GI cancer, asymptomatic lesion and treat them at an early stage. And as a result, save lives. You can see the patients who had screening and the patient who had no screening. And even if the screening is not optimal, but you don't have MRI scan, only clinical examination or perhaps a CT scan from time to time, you can save life. And this is very important. That's one of the messages. This is the curve, the red curve in the middle here that shows that the patients who had partial surveillance also had a survival benefit. So keep in mind that when you identify a syndrome, you can also implement surveillance to have an early diagnosis and prevent late diagnosis to happen. So overall, this is a really challenging issue. We are not sure that earlier diagnosis will improve survival. The debate is ongoing, but certainly we can do better. There are a number of successful initiatives. You will hear from Dr. Mushtaq as well in Pakistan. And collaboration and exchange of ideas, particularly in low and middle income countries, will be important. You have here my email and you can contact me anytime. Thank you very much.
Thank you so much, Dr. Eric Bouffet. That was excellent. I now have the pleasure of introducing Dr. Naureen Mushtaq, Associate Professor and Pediatric Neuro-Oncologist of Aga Khan University in Karachi, Pakistan. Dr. Naureen is the head of the Pediatric Oncology Division at Aga Khan University in Pakistan, and she is the only pediatric neuro-oncology surgeon, a pediatric neuro-oncologist in Pakistan. She is building a very strong division there, including a pediatric neuro-oncologist fellowship. She is working with an excellent twinning initiative with the Toronto Hospital for Sick Children. And she is the co-author of many articles in peer-reviewed journals. So I will turn the attention to everyone for Dr. Naureen's presentation. Dr. Naureen, the floor is yours.
Thank you so much, Dr. McCall. And thank you, Dr. Sohail, for inviting me to give this talk. My today's talk is close to my heart because it's the diagnosis and referral pathways of pediatric brain tumor in LMIC. So I have no disclosed conflict of interest. So as we all know that pediatric brain tumors are the leading cause of cancer-related morbidity and mortality in pediatric years. And incidence is 2.5 to 4 per 100,000 per year. So this is actually developed country data, not the data from LMIC. So initially when I became a consultant, so I used to think that, brain tumors, oh, this is uncommon. This is not the commonest one. So we always think that leukemias and then lymphomas, neuroblastoma, Wilms tumors are the commonest, and the brain tumors are slightly lower, as Dr. Eric said. But actually, it is the most common solid tumor in pediatric age group, and second to after leukemias in childhood age. So as the table showed, that it's the highest, and in fact at AKUH where I'm working, so as we are the center in which all the subspecialties are under one roof, So we have the highest number of brain tumor as compared to the cases we used to see for leukemias and lymphoma. So we used to see around 80 to 100 new cases, brain tumor from 0 to 18 every year. So the classification is slightly different as we used to talk about the other tumors like maybe rhabdo or other things, Wilms tumor or retinoblastoma. So the brain tumors can be divided into different types. It may be benign and malignant. So although if you talk about a benign disease, which means it's not cancer, but if you see the outcome, so it's still 60%. And this is not actually the total outcome. This is actually the morbidity brain tumor used to cause even when they are benign. We all know that the brain is the master of your body. And if there is anything happen in the brain or at the particular site, so the control of the body part on that site can be damaged, or it just a person can lose the function. So the low-grade glioma, if resectable, the outcome would be more than 95%. If it's unresectable, it's 80 to 90%. And again, depending on the site of the disease, the site of the tumor. The poorer, the non-accessible site like optic gliomas, pontine gliomas, and thalamus is really unresectable. So here comes the morbidity, which is related to the benign tumors. Then we have the most controversial one, the craniopharyngiomas. The outcome is although 80 to 90%, but it can carry a significant morbidity associated with cranios. Although it's not a cancer. It's just a benign disorder. So then comes to ependymoma. So many ependymomas are benign disease, but again, they can be notorious. As Dr. Eric showed the image of the spinal cord ependymoma, they are the ones who has a long history and usually get undiagnosed. And when they present it, they have such massive involvement. So even the benign ependymoma can cause significant morbidity and even mortality. So, but if we talk about the malignant disorders in the brain tumor, the most commonest one is the medulloblastoma. And this is the most common brain tumor, which as oncologists, we come across all the time because medulloblastoma is chemotherapy. So the average risk of medulloblastoma in the West carries a very good prognosis, like more than 90%, and some of the molecular subgroup of medullo like Wnt. But in general, if we talk about LMIC, the outcome is of average risk is not more than 50 to 75%. And for the high risk, it's 50% and even less than that. That we have germ cell tumor, which is malignant, but with an excellent outcome and a good quality of life. When a patient has germinoma, it's more than 90%. But when we have a non-germinomatous germ cell tumor, the outcome would be 60 to 7% in general. And the worst one are the high-grade glioma. And the most heartbreaking diagnosis is the DIPG, that diffuse intrinsic pontine glioma, which is a high-grade brainstem glioma, and its outcome even less than 10. And if you talk about like from LMIC, there is no specific data for DIPGs, but I can assure that it may not be more than 5 to 10%. So this is just how many pediatric brain tumor we used to have. So we have the most commonest tumors are not medullo, although we come across with medulloblastoma most of the time because it needs chemo. But the most actual commonest tumors are the low-grade glioma, which is more than 36%, followed by medullo, then high-grade ependymomas, cranios, so on and so forth. So as far as the risk factors and the family history is concerned, so there is not like the gender, we don't find any differences or any specific risk factors for brain tumors, not even for the diet, but there is no data which can tell us that maybe maternal diet during pregnancy can have some relationship with the risks of developing brain tumors. Then the family history of seizures is still inconsistent. But the most important thing is the family history of brain tumor and consanguinity. So there is an increased risk of 3 to 9% reported, which may be explained by the cancer predisposing or the genetic conditions which can have brain tumors. So as a pediatrician or as an oncologist, before, when I was a resident and a fellow, I never give enough consideration of asking the consanguinity, although in Pakistan has the highest consanguinity rate. And then, of course, the family history of cancer. So we just skip that part. So for all of us, this is extremely, extremely important that we should have the history of consanguinity and the history of brain tumor. We have to ask specific questions to the families that do you have a patient with a T-cell lymphoma, a colorectal cancers, or other cancers, and what is the age of the patient? Because the younger the patient, the more chances of them be associated with some cancer predisposing syndrome or genetic conditions. So there are various papers which coming out for this association. So medulla can be associated with gonorrhea. Then ATRT can be associated with INI1 germline mutations. Then there is a very, very important category which is known as constitutional biallelic mismatch repair syndrome, which can also mimic NF1 patients. But always ask the family about the history, as I've already told you. And most of these patients with the constitutional biallelic mismatch repair syndrome have Kapoor spots. That's why they usually misdiagnosed as NF1 patient. But NF1 patient has low-grade gliomas, and the children who presented with the CMMRD usually has high-grade gliomas. They may have a colorectal cancers, T lymphomas, and other cancers, maybe leukemias at a very early age. But the suggestive criteria includes family history of GI cancers, normal growth, normal IQ, and consanguinity, of course. Then Lee-Fraumeni syndrome, that's an autosomal dominant syndrome, again associated with CNS sarcomas, bone sarcomas, medulloblastomas, and breast cancers. So please do consider and do emphasize on asking the history of different syndromes or history of consanguinity. So this is a very good diagram which tells you about the symptomatology of a pediatric brain tumor. So on the right side, if you see, so there are 3 scans in which the first one showed supratentorial tumor and a tumor at the frontal area. So whenever you have a tumor at the frontal area, these children usually presented with personality disorders. And then if a child is presented with visual disturbances, they can have optic pathway gliomas. Then maybe a child presented with raised ICP, or maybe presented with movement disorder, can have a posterior fossa tumor. Then on the left side, they may presented with seizures when they have cortical tumors. They may have craniopharyngioma at the suprasellar area, so they may have endocrine problems like panhypopituitarism. And if they have a recurrent respiratory disorder or aspiration causes by the purple palsy, they may have a pontine lesion. So please do consider asking all these questions, and keep in mind one of the diagnoses can be an SOL, which is a space-occupying lesion or brain tumor. So these children can present with the psychological issues like anorexia, behavioral changes, depression, psychosis. They may have abnormal community. They have basically abnormal. They have developmental delay. They have increasing head circumference. They may have presented with seizures when they have a tumor of the cortical areas. They have growth problems, they have papilledema, and when they presented with hydrocephalus, they may have continuous vomiting and headaches. So please, and smaller kids can have macrocephaly. So please do consider these symptoms. They can be brain tumor other than the regular symptoms, gastritis or psychological disorder you are thinking whenever you come across with any child with symptoms. So I just add some of my cases, which are like lessons to me, and I never forget these cases. So this first one is a very unfortunate kid who presented to us at the age of 4 months when she developed seizures. So at that time, a scan has been done which showed a suprasellar mass. The parents advised for the surgical resection, but they never opted. But they continue follow-up every 6 months to the pediatrician or the neurologist. once they went to the neurosurgeon and he advised the surgery, but they just, they don't want to have the surgery, but they continue just follow-ups and do nothing. So when she presented to me first time, she was a 4-year-old with a weight of only 4.8. So she's just a tiny little girl, a very pleasant looking girl, but she's completely blind. And what she has a massive tumor in the suprasellar area. It was a pilocytic astrocytoma, and this child has diencephalic syndrome. So we, as pediatricians and pediatric oncologists, completely missed the diagnosis. And so as Farah said, and Dr. Eric said, that maybe if we diagnose her early, she may have a better outcome and a better quality of life. So this unfortunate kid was started on weekly vinblastine for a month or two, but she developed stroke, and then she died within a couple of months later. So the second case is a 10-month-old baby who came, who went to various pediatricians, various doctors, but one ophthalmologist advised an MRI brain. He had proptosis. So when the MRI has been done, this boy has a bilateral optic pathway glioma. If you see this scan, so you can easily appreciate the enhancement pattern and the bulbous optic nerve, like a swollen optic nerve. And then, so initially we have started him on weekly vinblastine to salvage the vision. But he remained fine for a year of chemo, but then he developed deterioration in vision again. So we had his biopsy done, and it was turned out to be a pilocytic astrocytoma. Again, maybe we can diagnose him 2 or 3 months earlier, so he may have a better outcome. But he received BRAF inhibitors on compassionate access program, and he remained well till he had the drug. So the third one is a very common case, and many of our pediatrician and neurologists come across with patients like these. So this is a 14-year-old boy with generalized tonic-clonic seizure for the last 8 months. He went to various pediatrician neurologists. There was an MRI done after 8 months. And initially people were thinking that he may have Adams. This is a significant involvement of 3 consecutive lobes of the brain. And then a biopsy had been done, and it was a glioblastoma. But unfortunately, the child died because he came very late, and this is a massive disease, and we couldn't even start radiation therapy on him. So another case, this is again a very common scenario, even in LMIC, like in Pakistan or India or any other country. So this is a 12-year-old boy with headaches for 2 months, seen by multiple pediatricians. Someone has advised for that it was a TB, tuberculosis, and he received 2 months of anti-TB medications. But the thing which was missed was the history of consanguinity. This family has significant consanguinity, and 2 of his cousins, first cousins, died in different families, near families, with brain tumors. And both these 2 boys have glioblastoma. And this child came to me with this lesion, and I advised them to have a biopsy, but they were quite adamant that no, it's TB. We have to continue the anti-TB drugs. But then I repeated the scan, and this was so his disease has progressed, and when their biopsy has been done, it was a glioblastoma, and it's a CMMRD positive glioblastoma, and this unfortunate kid died just after 2 months of diagnosis. So another one is a 14-year-old boy, headaches, diplopia for 2 months, the same history as the previous one, treated for encephalitis Adams. MRI showed significant involvement of 3 consecutive lobes of the brain, and the neurosurgeon called me from the OR and said, Naureen, I have gone inside, and then I have just, tried to do a biopsy, but it's not a tumor. It's just diffuse sheets of some cells. And then I advised them to have a biopsy from 3 different points. And unfortunately, it turned out to be, again, a glioblastoma with mismatch repair deficient disease. They also have consanguinity, and this unfortunate boy also died after 6 months of radiation therapy. So this is another boy. Again, a common scenario for pediatricians and neurologists. So this is a 10-year-old boy who has who is slightly mentally challenged, has history of generalized tonic-clonic seizures since the age of 5 years. He's taken, I think, at least 4 anti-epileptic when he came to me. He has significant macular facial rashes with mild development delayed, and the MRI showed this. So these are subependymal giant cell astrocytomas, and this boy has SIGAR. And he also has this H-leaf spots, which is a criteria in tuberous sclerosis. And we have started him on everolimus, that an mTOR inhibitor, and he's doing fine after that. He's still on my regular follow-ups and he's doing okay. But again, when you have a patient with all these symptoms like macular rashes, angiofibroma of the face and hypopigmented areas, and a scan like this, one consideration is a tuberous sclerosis patient. Then this is a 13-year-old girl who came to me with a history of fall for the last 4 months, headache for 2 months. On the CNS examination, she had right-sided hemiparesis, mild dysmetria, broad-based gaze and nystagmus. She had a pontine lesion, but it's not a typical pontine lesion. So we have discussed with our neurosurgeon, and he's very brave enough to have a biopsy, and was a pilocytic astrocytoma. She was started on chemotherapy and then she became fine. So this is one diagnosis you can have in your patient, and they may have a brain tumor and they can be alive even if they have pontine tumors. So this one I just skipped because it's the same case. Dr. Farah has showed you the medulloblastoma case. Then the last one is a 2-year-old boy presented with a history of vomiting for the last 3 weeks. He admitted twice in the ward under the pediatric specialty, and he was treated for gastritis. But when he went home, he developed right-sided weakness, and the parents took him to an orthopedic surgeon, and the orthopedic surgeon is clever enough to advise them an MRI brain. And the MRI brain showed a massive bifrontal tumor, and it was an ependymoma. But this is quite massive with hydrocephalus. This unfortunate boy underwent resection 3 times, received radiation, but as the disease was extremely, extremely big, so he died after a year or so after radiation. So these are the low-grade gliomas, which is, the most common one is the pilocytic astrocytoma. And this is the most common brain tumor that can kill depending on the site of the disease. So if resectable, has an excellent outcome. Not resectable, they need chemotherapy instead of radiation. We have to keep radiation. So always remember, discuss your patient with the tumor boards, with the multidisciplinary tumor board, so that you have a better outcome. Many causes of delays, but please take a good history and physical exam. Always remember the triad: headache, vomiting, papilledema. In attention, do not give, you have to give attention to the common symptoms which are persistent. Behavioral issues and school problems should be considered also. And you have to keep an eye on what the parents say and the parents complain. So this is the way you can have better understanding of the diagnosis and may, diagnose these cases earlier. So just a few seconds for the Head Smart program. So this is an excellent program which help the UK to, so this is, in this program, they basically have awareness sessions, and they have developed surveys in which what they'll do is they decreases the total diagnostic interval from 14 weeks in 2006 to 3.3 to 1.4 weeks in 2013. So then this is an excellent program, excellent initiative. And how so this is again because of the awareness and development of these common cards, in which they have provided the healthcare professional these cards, so that when a child is presented with these kind of symptoms, they should refer to us tertiary care center for further treatment. So this is the initiative we have developed in Pakistan. It's a childhood brain tumor initiative of Pakistan, and any parent, caregiver, teacher, and doctors who have a patient with a brain tumor can register their child on this link. They go to this link, Then this form opens. You have to fill up this form, and then you have got this thank you message. And our team of neuro-oncologists and fellows will talk to them on Friday, every Friday between 4 to 5 p.m. And we have developed a collaboration, collaborating centers, like in 13 different centers of Pakistan. We are doing capacity building. And in those, so we'll refer this patient to their near collaborating center who are doing neuro-oncology. So that, delaying of the diagnosis and abandonment can be prevented and give these patients a better outcome. So we all know that we cannot do much for the poverty, illiteracy, and inadequate treatment centers, but we can, help these patients and help you with the help of different societies like SIOP, like Pediatric Society, Family Medicine, and Neurosurgery Society. One initiative is to develop twinning initiative among yourself and develop national tumor boards to help healthcare professionals for appropriate management and good quality of life of these children. So this is my last slide. So we have developed this capacity building. So we have developed this collaborating center and national tumor boards across Pakistan. So we are doing 4 tumor boards per month since 2019, and 103 tumor boards has been done. And more than 468 cases have been discussed in these tumor boards. And these 13 centers are from across Pakistan. So, so many centers are part of this collaborating initiative. And they are now being able to establish their own tumor boards, and they're helping their children. So this can be done in any part of LMIC. So thank you so much. And I'm really sorry that I've taken so much time. So I'm happy to take questions.
Thank you so much, Dr. Naureen, for a really informative talk. That was excellent. We do have some questions. Thank you, everyone, for your questions, and please continue to share any questions that we'll come back to. I'm now going to invite our panelists to join us, and I'll just reintroduce them. So we have joining us today as panelists Dr. Anthony Figaji, who's Professor and Head of Pediatric Neurosurgery at the University of Cape Town in South Africa, and also National Research Foundation Chair of Clinical Neurosciences and Secretary and ex-Scientific Chair of the International Society of Pediatric Neurosurgery and Pediatric Director of the Brain Trauma Foundation, as well as one of the founding members of Global Neuro. We also have as our second panelist, Dr. Shaarna Shanmugavadevil, who's currently working as the NIHR Doctoral Research Fellow in the United Kingdom, doing a PhD at the University of Nottingham on childhood cancer diagnosis. We've heard quite a bit on the HeadSmart campaign from a few of our speakers today, and Dr. Shaarna worked as the HeadSmart Fellow with Professor David Walker between 2015 to 2019, and now serves as the clinical ambassador for HeadSmart. Lastly and importantly, we have Dr. Hikari Ambara Sjakti, who's joining us representing the International Pediatric Association. Dr. Hikari has been serving in pediatric hematology oncology at the Cipto Mangunkusumo Hospital in Jakarta, Indonesia since 2006. So welcome all the panelists who are going to make some comments, and then we will head into answering some questions. There is a question that we haven't got to about from Dr. Yudis Jayaprabowo from Indonesia, who's asking a question about imaging, which I'll read out aloud, and that might be a good starting point for the panelists, about a question around, is there any imaging between the CT scan, a non-contrast CT scan, contrast CT scan, and an MRI in terms of diagnosing pediatric brain tumors, knowing that these imaging modalities may not all be available depending on the location. So I invite the panelists to make any general comments about the talks and specifically discuss this question. Thank you.
Thank you for inviting me, and it was really brilliant to hear all the speakers today. So that was really insightful for me from a high-income country. The question's a really good one, and I suppose we're blessed to be in a high-income country, and so we say that the gold standard investigation, certainly in the HeadSmart guidance, is MRI. But I appreciate that's not something that's available everywhere. So I would welcome other people's comments.
So if no one's going to make a comment, I want as well. I presume the comment is specifically in the context of resource restrictions. And in resource restrictions, it's all good and well to have a gold standard as a high definition MRI. But the reality is for the majority of places that don't have access, and access is about having the MRI scanner, having the maintenance contract, having an anesthetist to put children to sleep safely if they are young, which the majority of them are. But the truth is, from a large part of their destiny is going to be access to surgery, and in most cases, the bulk of your decision making can be done on a decent quality CT scan, even without contrast. That's the truth. And then getting histology and taking out most of the tumor safely, you can usually get by on a CT scan. In most circumstances, the diagnosis is reasonably obvious, and perhaps not the definitive diagnosis, but the reasonable diagnosis is fairly obvious in the majority of cases. The problem often in low and middle income countries is they very often don't even have access to CT scans, or where they have access to CT scans. This is true for Africa in particular. The patient or the patient's family, or by extension, the patient's family's village, has to pay for the scan. And then once they've paid for the scan, they're going to pay for the treatment. They've got hydrocephalus, they're going to pay for the shunt. So having access to imaging is going to really, really important. It's part of a larger package deal. And we can talk more about it a little bit later, but I think there are a few strategies that the oncology community across the world can have in terms of granting that access to imaging. And I don't feel that there's enough advocacy in that area. And maybe we can discuss that a bit later. But that would be my answer to that question.
Thank you, Dr. Anthony and Dr. Shaarna. Dr. Hikari, I would be interested in your perspective.
Yes, it is an important issue regarding the ability to diagnose the pediatric brain tumor in our hospital. But it is an important issue to provide facility in most country in IPA member. A lot of them are MIC countries, So maybe we have several patients that cannot be diagnosed. And also, as Dr. Eric mentioned before in his presentation, some patients maybe died before diagnosis. And of course, we need at least a CT scan with contrast if MRI is not available. But sometimes it is not provided in several countries or hospitals. And it is a limitation for the neurosurgeon also to perform the procedure to diagnose this patient. So we need to overcome these problems in many countries, in LMIC countries, but maybe we have to overcome this together between society and also between multinational collaboration, maybe. Thank you.
So maybe there's a good question in the chat that came recently on visual symptoms, and that these are also unspecific, and that sometimes ophthalmologists are not readily available. How do you foresee this being tackled in LMICs? I think it's a question similar to the CT scanner and imaging availability. And I think this is something that Dr. Bouffet mentioned in his talk as well. Any insight from our panelists?
So if I can answer, I think the nystagmus is a very, very important presenting symptoms. And many children, in fact, with what Dr. Naureen presented as a diencephalic syndrome, this child was very skinny and eventually died, unfortunately, is a very clear example. Any nystagmus should be an indication, and particularly when it's not present at birth and then noticed by the parents, should be a reason to do an MRI scan or a CT scan if the MRI scan is not available. Again, it's very important that you listen to these parents who come and say, I think my child has a shaking eye, because that's how they come. They don't say has a nystagmus, they say has a shaking eye. And that's a very important symptom. And I think diencephalic syndrome is certainly one of the conditions where earlier diagnosis may save vision and may also make the treatment a bit easier, because we know that these symptoms are the presenting symptoms with diencephalic sign is associated with a more aggressive disease. So if you can pick the diagnosis earlier, before the child is obviously developing symptoms of hypothalamic damage, this is even better. So remember, shaking eye, that's what the parents, they come with as a sort of what they have noticed.
And I would, if I could add to that, I don't think access to an ophthalmologist should be a hurdle in any way for most visual problems in children, and we can anticipate exactly what they are. You know, a good clinician is going to be able to deal with that, because the problems are going to be nystagmus, which Professor Bouffet mentioned, which is pretty easy to diagnose. Visual fields, and those are fairly easy with confrontational tests. Visual failure, even if they don't have access to charts, and one of our previous oncologists who's passed on used to have a little Smarties test, put a whole bunch of little sweets, colored sweets on the table and see how they pick them out. And it's a rough and ready way of detecting visual failure. Or they're going to have a cranial nerve palsy, they're going to have a 6th nerve palsy most commonly. Again, you can pick up that quite easily. Then they're going to have optic atrophy, papilledema, again, being able to dilate the pupils and kind of do fundoscopy should be really within the skill set of most clinicians or pediatricians. So I don't think access to an ophthalmologist necessarily has to be a hurdle.
Thank you so much for that response. You know, thinking about what are the tools and the skill sets that are possible. We have a very interesting question here in the Q&A from a registered nurse in Uganda, Owu Muhangi Dan. And I think her question is a very good one about the ways that the nursing staff can play a role, since in many cases in primary care, a young person, a child who may be suspected of having a brain tumor will get his or her first evaluation with a nurse. It reminds me of the need to establish these clinical teams and make sure that all members of the team are appropriately sensitized and have some knowledge about the ways to expedite referrals. So I'm wondering if any of you have some suggestions for our registered nurse, Ms. Ohangi Dan, about ways that the oncology team or primary care team can enhance and expedite diagnosis and referral. Thank you.
So thank you for the question. So what we have done at our center at AKU, so we have hired a nurse navigator, and he's the one who is doing all neuro-oncology, both adults and pediatrics. So this is a very this is a very excellent source that the nurses, that if we educate them, they'll be the first one who encounter patient when they are admitted in the wards or in clinics or everywhere. So their teaching is extremely important. And one option is to have a nurse navigator, maybe either leukemia, lymphoma, or brain tumor, who can kind of manage these patients and help these patients and families. If you don't have the availability of like a social activist, a social care worker or school worker, something like that, so maybe a nurse navigator can be very helpful in coordinating the care between the different specialties.
So I want to show you again, and that's a work that was done by Dr. Walker, and showing, and these cards are readily available on the HeadSmart website. And it's something that you can share with nurses, with also teachers, anybody who is working in close contact with kids, and they can read it and remember this. And that's really a tool that is critical in any country. And I really value the translation in Arabic by Dr. Amayari, because that's also a wonderful tool. And I think it should be translated in different languages. I think this is something that Dr. Walker is doing or planning to do.
Thank you, Dr. Naureen, Dr. Eric. I'm interested, Dr. Shaarna, have you had any comments having that so much input with HeadSmart, and if you had any other comments, and also whether does that implementation and education, has that been also including nursing staff as well, and how's that, what's that strategy been in terms of disseminating that information?
Yeah, I think the really important thing that we found is having a standard operating procedure or a guideline. So I think the initial question was, how do we expedite diagnosis? But I suppose we all need to be on the same page wherever you're working in your base, where how is best to get to the investigation, or who the child needs to see next. And I think that's what we initially did with HeadSmart. So was developing a guideline that had input from everybody. So it had input from general practice, from A&E doctors, from oncologists. So everyone that would potentially be involved in that pathway had input into what the guideline looked like. And then the guideline was translated, like Professor Bouffet said, into these really easy to use symptom cards. And those symptom cards, we have had to, initially we were using them for parents, but actually the healthcare professionals were saying, this is great, because in a 10-minute consultation, if a child presents with one symptom, all I need to do is ask whether they have, you're asking for the presence or absence of the other symptoms, which will then give you an idea of whether that child needs further referral or investigation. So we said that if there's one persistent symptom, you would go and see your GP. And if you had two or more persistent symptoms, then that child warranted a scan. So in the UK, that would be an MRI scan that they would go for. So I think that has really helped. And part of my role as the HeadSmart Fellow was going to different conferences and GP surgeries. And sometimes I'd go to 4 or 5 GP surgeries in a day to talk and educate, and it's really hard when there's only one person to do it, but we've tried to put all the resources into e-learning modules so that they can be more sustainable, so people can use them. And certainly Professor Walker has set up a group that's being led by Dr. Adam Green in Colorado, and so that other countries can come together and translate whichever materials they would like. So we've had, obviously, in Jordan, Naureen has translated the whole program, but we've also had Argentina, who've literally just translated some of the materials and have produced their own educational programs going forward. So what we found is that awareness and education has been really, really powerful to drive forward earlier diagnosis. And that can be done, where there's a will and there are people that want to do it, it can be done anywhere.
Thank you, Shaarna. That's really helpful. There's a question as well that's probably relevant about from Dr. Saeed from Pakistan about delayed diagnosis and creating awareness at the primary care level. And I think HeadSmart sounds like that's very much where it's also targeting, and hopefully could be used in different settings. I'd be interested to hear from Dr. Anthony if there's any, if you have any thoughts about how to also use those strategies to try and engage neurosurgical colleagues as well.
Sure. I agree that the major issue is advocacy, particularly in low and middle income countries. And if I speak from an African perspective, Cancer doesn't get the attention that it deserves, cancer in children. And if you look at the funding that comes into Africa for both for research as well as clinical care, cancer really doesn't register much. So it's infectious diseases, so it's the big three, TB, HIV, malaria. The Wellcome Trust, Bill and Melinda Gates Foundation, and several other funders are not particularly interested in children's cancer, and that's a real problem, because we could change survivorship massively with a few very, very basic interventions. So one of them, of course, is access to surgical care, and that's true for pediatric brain tumors, and obviously I'm biased in that. But if you don't have a surgeon who is going to at least get histology, at best take the tumor out, and deal with some of the complications of tumors like hydrocephalus, you don't have a hope for survivorship overall. So access to surgical care is a basic human need across the globe, and I don't think we've advocated enough for that. So that's the one thing. The other thing is access to imaging. So as I said earlier, it's all good and well being very aware of head smart type symptoms and having those kind of education initiatives. And I think that's great. And we've been teaching that to our medical students over several generations. But the problem is, if they land up in a place where they can't act on it, then it still doesn't advance the care of children. And the basic part of the act that we've all spoken about is, you think of this symptom, you see a child with their head tilt, and you think the child must have a brain tumor. And then the very first thing you do is you got to get imaging of the brain. And for various reasons, that in so many centers all the way across Africa, that's just not an option. Well, it's not an easy option, because I told you, you have to have access to the scan, you've got to pay for the scan, etc. So that's a big part of our advocacy if we're really going to change the outcome for children. And I just also mentioned that there are some alternatives to CT scans, right? So I don't know how many of you know about the hyperfine swoop low field MRI scanner. Well, there's not a lot of heads nodding, so I presume that not many of you do. But it's an amazing technology. It's a portable MRI scanner. It doesn't give you fantastic images, but you can diagnose hydrocephalus, you can diagnose a brain tumor. Its maintenance is really, really low. When it first came out on the market, the company was selling it for a kind of a relatively low amount of kind of initial investment. I think it was about $70,000. We've got a unit here in Cape Town. There are several units all the way across Africa, but they're not funded for a lot of the clinical things that we would benefit from. So at the moment, Bill and Melinda Gates Foundation, for instance, are funding it for developmental studies in children. Whereas actually for trauma and infection and cancer, it would be an absolutely ideal technological intervention, because it's so easy. It's small, it can be, it's mobile, you can put it in a truck. You just need a plug point to power it up. You don't need any protections around it. You don't need a radiologist or a kind of a trained radiologist to run it. It's really, really easy. These are the things that we should be advocating for throughout Africa or low and middle income countries. So anyway, so that's a little bit of a rant, but the point is access to imaging is something that we don't often discuss. There are things that we can do about it, and if we're going to move outcomes for children forward, that would have to be a central part of it.
Thank you, Dr. Figaji. That was good to close out, and thank you to all the speakers from today's sessions and all the panelists. Obviously, this is a very important topic, and I think we could be chatting for this for many hours. But we're a little bit over, so we're going to close the session for now. Here in the slide, we have Dr. Sagir Khan's email, who is one of the leads of the CEDAR project. We appreciate everybody connecting and being involved in the questions. There is CME credits available for today's session. And then finally, this is the fourth webinar of the CEDAR series. The prior ones are in the links that you see on the screen there. There was one on the global childhood cancer landscape, one on acute leukemias, retinoblastoma, and this was the fourth one. The next one will be on the 20th of January 2023, and that will be on Hodgkin lymphoma. I will pass the word to Dr. Farah to close out the session for today.
Thank you so much, Dr. Daniel. Let us conclude this webinar where we started, with the understanding and appreciation of the importance of early diagnosis and appropriate treatment of children with brain tumors. I think that we have, as was said, a lot more work that we need to do, but certainly sensitizing the important team members, the pediatricians, the nurses, the neurologists, and neurosurgeons about the need for access to those important tools. I think we've learned a lot. We've touched on the important topics of Head Smart, tumor boards, and innovation and technology that's needed to increase access to appropriate scanning techniques. I want to thank the panelists and speakers, and also to thank our moderators. I really appreciated the privilege to be part of this, this webinar today. I want to thank also SIOP, and especially their Division of Education and Training Committee. I also want to thank the International Pediatric Association for their partnership. I wish all of you a wonderful day and Happy New Year. Thank you very much. Bye.
Thank you. Thank you again. And Merry Christmas. Happy Hanukkah. And
yes.
Have a wonderful holiday. Thank you.
Yes, thank you so much, Dr. Bouffet. And thanks to all, especially our interpreters and the staff of SIOP, Dr. Sagir Khan, for his leadership. We are really grateful for this opportunity.